Hello and good morning, everybody. Thank you so much for being here with us today. Today, I am joined with the wonderful Dr. Casarett and Dr. Grudzen, and I could not be more excited to get this episode kicked off and started. Now, y'all know me. I love a little lightning round to get things going and shake things up. So to kick things off, I have to know, coffee, tea, or energy drinks? And what's your ER shift fuel of choice?
Definitely coffee, iced, and lots of water.
There you go. All right. That's great.
And from my perspective as a researcher, one of my favorite questions, you have a lot of research grant money. What's the craziest, silliest thing you've had to use grant funding for?
Oh my gosh. Well, we never use grant money for anything silly because we're not allowed
I know.
My own time. I buy out my own time. That's kind of silly. But
there you go. Hey,
yeah.
That's a good answer. All right, this might want to be a tough one, but emergency medicine or palliative care, which one do you think requires more patience?
Oh, interesting. Honestly, I don't think either require patience. They're just at a different speed.
Yeah. Interesting. That's certainly a hot take. I like that. Yeah. I like that.
Yeah. Neither.
Although in the ED, you guys move faster than we do.
Yes. Absolutely.
Dr. Casarett knows from experience.
Yeah. You guys see 4 or 5 patients in the ED in the time that it takes me to see one.
True.
You all wear scrubs a lot in the ED, and coming from somebody who made it through 3 horrendous years of COVID wearing scrubs every day, I hate them. I assume you hate them too. How would you redesign scrubs to make them more stylish, more fun, more something?
You know what? I'm super old school. So my favorite scrubs were from medical school. We had these at San Francisco General, which now is Zuckerman, whatever. They would launder them constantly, and they were so thin. They were almost like paper, and they were purple. It was so San Francisco, kind of maroonish purple. Ooh. And those were my favorites of all time. My favorite is like super used, very clean, but like very worn down. So they're more breathable.
Absolutely. No, I definitely like my worn-in scrubs better too. They take a little bit of time because they can be stiff at the beginning. When
they're stiff.
Yeah. So I love that answer. I really do.
A startup idea. Maybe we can create like upcycled scrubs.
It's brilliant. Old school upcycled scrubs.
That's a great idea. Yep. We're going to have to get Neelan on that one.
From old hospitals, like county hospitals that no longer exist.
Like old linens from like hospitals and stuff like that.
Yeah.
And it's sustainable too. So 2 birds with one stone.
I love it. All right. We've got a career plan here.
I am curious to know now, what's the weirdest thing someone has brought into the ER that made you like have a little belly laugh?
Oh my gosh. I did residency at Bellevue Hospital in New York City, and there are just so many things. But I think I would say back in the day when people would bring a dog, that was really bizarre. Nowadays, like there's so many people that bring their pets everywhere, but like
into the emergency room, that is certainly a little interesting. For sure.
And like couldn't leave, like refused not to have them. Yeah. So you would walk in and like look under the curtain and see, a leash attached to a dog. It was just, it was lovely, but it was definitely
not the surprise that you were expecting.
Yeah.
I love it. I love that.
And last in the lightning round, sort of a selfish question for me, you go into a room, you explain you're an ED doc who's also a palliative care doc, and you get the typical response of, oh, I'm not ready for that. I'm not in hospice. What's your response?
I would say palliative care is about living. I was thinking about this morning, and that's the lightning round answer. We can get into more deep stuff, but I think it's really about living, not about dying. So.
I love that. Honestly, I should retitle like all of our palliative care stuff. Palliative care is about living.
It really is.
That's wonderful.
Yeah.
That's really great. Well, thank you for indulging in our lightning round questions. That was super fun for me. I would really love to know. So we have some busy professionals watching this podcast. So if someone can only listen to the first 5 minutes of this interview, what do you hope that they walk away with?
I think we I guess the headline, if someone is working in healthcare, I think sometimes we put a lot on patients and families.
Mhm.
And as things get more and more difficult, we put more decision making on them rather than the opposite. I think sometimes making a recommendation can be actually the most thoughtful thing to do. And especially when we know that there really aren't a lot of options left, making a recommendation can kind of take the heat off the family or the patient. It doesn't mean that we're not aligning it with patient values and choices and all those things. But I think somehow when things become crystal clear, we have trouble making a recommendation.
Right.
Whereas when things are, should we give antibiotics? Should we not?
Mhm.
We more easily give recommendations on things that are easy. So I
great.
think we should give ourselves permission to do that
Yeah.
when it's really clear what the most important next step is.
It's so fascinating. It seems like the two mistakes I see residents and trainees make most often are, first of all, not pausing at the beginning of a conversation to figure out where the patient and family is. They just launch into information. And then to your point, at the end of the conversation, just leaving it open and not providing recommendations. And it's so fascinating to me that those are two almost diametrically opposed failures, but we manage to fail in both ways in these conversations.
Totally. I think that's the second thing. Yes, I would say that is a great point. Not asking where what their understanding of the prognosis is, or where, like, that is, honestly, I should have said that. That's number one. That's we talk about like goals of care in a time pressured situation, starting with, tell me your understanding of how severe, your illness is or what your prognosis is, something like that, to kind of set the stage. Because if there's no understanding, or the understanding is mismatched, I think you need help, and it's not going to be a quick conversation by any means.
This is so fascinating. Just like hearing you guys talk about this stuff, I'm like, all right, let me sit back and be a guest for a second here. But it's what you're doing is just so cool, because you're literally saving lives in the ER while also simultaneously pioneering how we approach death and dying as a concept. So it's got to be kind of like the ultimate professional plot twist, I feel like. So how did you end up becoming healthcare's most unlikely death whisperer, as I'm choosing to call you today?
I think, to me, I like real life. I like real conversation, and I like things that are important to people's lives. Like I can do small talk. I'm capable of that, but like, to me, I dig in where things really matter to people. And that can be whether your prognosis is great and you're having emergency. It's a very real place. And I think it's such a privilege to be with people during emergencies, and also, when they're close to death. And I think I just find it just a privilege and super interesting. And I'm still learning at this stage. So, so I think it's really that the intensity of the emotions is the same,
Absolutely. Yeah, absolutely. I mean, I feel like a lot of the times, like, people even like compare like deaths that you expect to happen, like more so like, okay, this person has this illness, they have this amount of time left to live, versus like an emergency death, like, oh, this person was in a car accident, they were living like their best life, and suddenly now. So I feel like those are also very, very like different concepts, but also so similar at the same time. And we don't really talk about how similar they are. So it's really fascinating to see this kind of brought to life.
Yeah, it kind of strips away all the things that don't matter, right? When you have an emergency or when someone's dying, it's like all that stuff that we worry about day to day that really is not important just falls away. So
Absolutely.
It's also in the moment. I mean, I don't want to overstate this, but one similarity in a sense between palliative care and ED medicine is that we're usually trying to manage symptoms or help people make decisions in the moment, as opposed to more, I don't know, my friend Jason Karlovich called it desktop medicine. Or statistical medicine. It's reducing the risk of a cardiovascular event by 10% over the next 5 years. Like, that's really, really important, but it takes a special kind of person to go to the office every morning thinking risk reduction in the next decade. Whereas
that is
palliative care folks and ED folks are drawn to, what can I do to make this person better, healthier, whatever, in the next 5 minutes, not 5 minutes.
That is so interesting. I could not agree more. Never thought about it that way.
Yeah, I love that. That was like such a perfect way of putting it, Dr. C. That was really,
You
really
should do an ED residency. What do you think?
You're welcome.
I'm all for it. I say I say do it, and I'll interview you in 4 years from now and see what your thoughts are then. So yeah, you kind of touched on this a little bit earlier about, when I was going through the lightning round questions, but I guess what's like blowing misconception that folks have about palliative care that you wish you could just like take a hammer to and just shatter right now?
Yeah, I would say that it's more about living than it is about dying. And I think it's actually completely about living, because if it was just about dying, we wouldn't be doing all the things that we're doing. And I think it's about figuring out, when time is short, what's most important. And sometimes there can be, the closer we get to death, the more clear things really are. And I think palliative care works its magic when things are a little bit more unclear. And so that's why, we have a program called hospice when things are really clear, when we've made a switch from focusing on disease, to really focusing solely on comfort. And I think, I would say that's the biggest misconceptions about how living well when time is short and focusing on relieving burdensome symptoms, on what's most important to patients.
Dr. Casarett, as I guess the chief of palliative care at Duke, I would also love if you could answer that question as well. So I guess, are there any misconceptions that you would wish you could, if you could shatter right now, that's I guess what you would do?
Yeah, in terms of what's patient and family facing, I would agree with what Corita said. I didn't have anything to add there. I think we face the same challenges. I think the other misconception that I hear a lot, less from patients and families and more from colleagues and health system leadership, people nationally, is palliative care is all about bending the cost curve. It's about reducing expenditures near the end of life. It's reducing acute care utilization in the setting of serious illness. And I don't know of a single palliative care provider who gets up every morning saying, I'm going to reduce ED visits. I'm going to reduce 30-day readmissions. I'm going to reduce the cost of care for this older lady with dementia. Like, that's not why we do what we do. That happens to be sometimes kind of a nice, for health systems and insurers, side effect. But I think increasingly, and we're partly responsible for that. We've made the case here at Duke and elsewhere for growing, not only because we're improving quality of care and satisfaction and patient experience, but also because palliative care done right and in a way that respects patients' and families' preferences often results in a decrease in costs. Not all the time, not for every patient, but we've kind of gotten that reputation. Which
that's such a weird way of framing it, and I feel like that's really helpful for people to kind of understand, from a physician's perspective, rather than just this is what I'm seeing on the internet or something like that. So I do think I haven't really done a proper introduction, but I do want to share a little bit more about Dr. Corita Grudzen. So she is an emergency medicine physician, and she's literally revolutionizing cancer care by bringing palliative medicine into the emergency department. And she's also the head of supportive and acute care services at Memorial Sloan Kettering Cancer Center. And she's leading this groundbreaking research on how to better align emergency treatments with what seriously ill patients actually want and need. So if you could, maybe walk us through a moment when you realized that the traditional medical model was failing patients and families in a way that almost even kept you up at night.
Yeah, I would say it was in residency when I was bringing up Bellevue Hospital again. And we would have transfers from a nursing home, which was a public nursing home. So, the most destitute, kind of forgotten people in the world, really. And so they would be transferred, and often many might have had someone, a court appointed to make decisions for them. Maybe they were couldn't make decisions for themselves, or even if they could, I think I felt like my hands were tied in the sense that I couldn't do what I felt like was the right thing, and that we had to do what was expected. And so I think, it really hurt there was a lot of moral distress in seeing these patients and feeling like we were torturing them literally. And I think, getting blood from them, or like just all the things we do to people that I knew there was nothing I was going to do with those blood tests that would make this person feel better or live longer or, all the things. And so I think, I didn't figure out what to do about that moral distress until much later, because palliative care really didn't exist at that time. But I think that was really it, feeling like, oh my gosh, I went into this field to really like have an impact. And there's this population where I feel like I'm doing harm. And so that was really what it was that, spawned the interest.
Especially when, like, I guess most people go into the field to heal and to help. And so just kind of being like, having to put your hands up and be like, that like, I guess the dissonance in your head would probably be really, really tough. I didn't even really think about that.
It was confusing.
Yeah, I bet. Like, thank you for sharing that. So like, I guess the other thing is, just as Dr. Casarett was saying a little bit earlier, emergency medicine and palliative care are like cousins, I guess, but also not necessarily siblings or like twins by any mean. They're very unrelated. Emergency medicine is all about, all right, split second decisions and, taking care of someone for like 5 minutes and like having to have them be okay within those 5 minutes. Whereas palliative care is more about deep and like thoughtful conversations and like kind of like planning and like setting things up for the future. So how do you like kind of like switch between these two completely different mindsets? I'm assuming sometimes even within the same shift.
Yeah, now, especially because I work at a cancer center, everyone I see has serious illness. So it's, we'll have a code, or I'll see, a leukemic who can be cured, come in with sepsis. And like, it's all about like everything. There's no goals of care in that situation. Like, this is a young person who has acute leukemia. They're incredibly sick. They could die if we don't do everything we can to stop the bleeding and, all those things. And then the next patient might come in, they're on hospice and they have a pain crisis and they come in. And so I think I don't see it so differently. It doesn't, I guess I don't know why I don't see it as that different, but it just feels like it's a continuation of the most important thing to recognize, which is like, where is this patient on in the trajectory? What do they need at this moment? What are their preferences? What is their previous, functional status? What are the goals of treatment? Are they still getting disease-directed treatment? And just figuring out where the patient is at. And sometimes literally looking at the patient, with some of the patients we have, they can look like they may be close to death. And honestly, especially with liquid cancers, they can be walked out a few weeks later and look, no worse for the wear.
Right.
And so I think it takes a little nuance, and more than a little nuance, but I think figuring out where patients are on that trajectory is just really important. And I do it no matter who the patient is. So I guess that's part of it. I think the part about palliative care that comes in is there's a lot more nuanced communication needed.
Right.
There's a patient who's, clearly, has a leukemia, who's here for cure and is just really, really, really sick. That's where I think, there are just tried and true communication techniques you can use to get you through those conversations that work and that are teachable and learnable and don't take a lot of time. I'm doing the easy ones, I admit. I think David's doing the more challenging ones. But I think, some people might say, well, why would you even have that conversation in the ER? You never saw them before. You're never going to see them again.
Right.
But I think what we know about decision-making is it's a process, and everyone, you don't just initiate something and everyone makes all the decisions they need to make in that one visit. I think things are a process, and you're building on everything that happened before and preparing for everything that's happening in the future. So I think it's just a really critical moment. And there's a phrase, I think in Chinese that's in English translated something like crisis is opportunity. And I think, often patients, when they come to the ED, they realize they're in crisis, and that's an opportunity to like there's been a
Right.
change in care trajectory.
Right.
So it's really important to make sure that they understand that and what
Absolutely.
the thoughts are, understand people's thoughts on that change.
Yeah, I'm really glad you said that, because I think, and palliative care has been responsible for this. We've really pushed this idea of advanced care planning and think and anticipate. And if this happens, what do you want to happen then? And what should we do if you come in with a small bowel obstruction? And I think you can get partway down the field with those sorts of questions. But I mean, we're ultimately pretty subjective beings, and we don't, and a lot of behavioral economics literature will tell us we're not really good in anticipating how we're going to feel in a certain circumstance.
Yeah.
And asking people to make especially binding decisions about what you want to have happen to you if you're in the situation, you can't anticipate what you're going to feel like.
Yeah.
You can talk all you want, but until somebody winds up in the ED in the middle of the night with small bowel obstruction due to ovarian cancer, I think that's often, unfortunately, the time that those decisions need to get made. Much as we try to help people at least anticipate those decisions, I'm not being a nihilist. I'm not saying we shouldn't talk about something until it happens.
Right.
But I think all of our conversations until that actually happens are necessarily incomplete. And so we really, for better or for worse, need to rely on our ED colleagues to help finish those discussions. I mean, and here at Duke, our ED docs are amazing, and we've done a lot of communication training. Becca Donahue here has led that charge. They've really done amazing work. That's not the time to have conversations. I wouldn't want to give that impression, but sometimes that's when those conversations need to happen, and that our ED colleagues are willing and able to do that.
Absolutely, 100%. And I love the way that both of you guys kind of like approached that. Dr. Grudzen, like I've just from like reading your like reviews and all of that stuff online from your patients, patient experience is clearly like one of your biggest focuses. And it really shows by the way you answer questions. I think that's just like so beautiful. But I guess, in your opinion, what are some of the biggest opportunities you see to improve the experience of patients with cancer and other serious illnesses that most other hospital systems are just entirely missing out on?
I think it's communication. How do we, and this is just so hard, but how do we, there's a phrase in palliative care, hope for the best, but plan for the worst. So how do you keep that, how do you keep that alive, but also make sure, that you're prepared for what the more likely result is. And I think there's an Emily Dickinson poem that I just read recently that I'd never heard of before that says, "Tell all the truth, but tell it slant," which is basically saying like communication is so nuanced, because we're not saying, you don't want to go in. I think before we would go in guns blazing and like, you know what, your prognosis is terrible. You should never go to the ICU. You should just get hospice. That's the opposite of tell all the truth, but tell it slant, Like, we're not saying we should lie to people, but we're saying that like, if you go at something really complex directly, it often just bounces right back at you. And so I think there's ways and, there's techniques that many people in palliative care have developed that I stole shamelessly and got trained by these people, and they work. And so it really is going at something kind of sideways, but it's still telling all of the truth, but it's a different way of delivering the message than just hitting people over the head.
Right. I think sometimes the other reason to come in from an angle, and I love that phrase, is because, especially in palliative care, by the time we're asked to see patients and families, it's because teams have been wrestling with issues of goals, and the team feels that they haven't made any progress, and the family still wants aggressive treatment, and so we're called in to try to convince the family. And the last thing you want to do under those circumstances is to beat people over the head. Patients and families have legitimately at that point developed antibodies to any bad news. And they see us coming a mile away, and coming in directly doesn't work. I think you need to develop a relationship. You need to see exactly why they're so reluctant to consider a change in goals. And once you have a relationship, once they know you, once they trust you, and vice versa, then you can begin having that conversation. But sometimes if families really have been browbeaten for a while, you need to slow down because it's not fair to them.
Absolutely.
Absolutely. I have a question that I would love if both of you could actually answer. Whoever can take it first. But if you guys could redesign the American healthcare system, and let me backtrack for just a second. I mean, healthcare is great. Like, obviously everyone needs healthcare, but there's definitely improvements that can be made in not just the US, but like the whole world, I guess, but particularly the US, especially these days, given how difficult access to care can be. But if you guys could redesign the American healthcare system, like you had a magic wand, you could do literally whatever it is you wanted, and you wake up tomorrow and that change has been like fully spread across the entire country. And specifically like the American healthcare system's approach to aging and dying, what would you change first?
Corita, happy to defer to you as guest. But if you need,
go for it. Go for it.
All right, I'll give you a quick
Don't
answer.
find it out too much.
The perfect one. I mean, I feel like with the health system, we built this incredibly complex machine and nobody really knows how to use it. It's like somebody delivers this really complicated new refrigerator and it has an instruction manual that's 100 pages long. And I just want to know how to keep lettuce from wilting. And this healthcare system is so complicated. I feel like we've kind of gone down that road, and you need like either a PhD in economics and biochemistry, or you need a family member who does. So if I could change one thing, it would be to make the health system more usable in both directions. People who really need care should be able to get it without multiple phone calls and a lot of Googling. And people who don't need that care should be directed in other directions. Not to eliminate care, but I think a lot of people wind up getting care because it's easier sometimes to get a prescription than it is to figure out how to use the healthcare system. So I'm kind of thinking of healthcare systems redesign as a UX UI problem.
I love it.
My 2 cents. But
I love I mean, I think that like as a whole, it would benefit everybody if we move towards more of like a preventative medicine like space where like we were trying to prevent issues from happening rather than just going and getting help when there is a problem that arises. So yeah, but
yeah, Corita, what do you think? I'd really be interested.
Yeah, I think that's wonderful. Could not agree more. The incentives are all wrong, right? It's I don't think we can solve anything until we change the incentives. I mean, we have some, fraction of our care at Memorial that's quality based for payment, but it's very small. I know it's more on the West Coast, less on the East Coast. I think we're getting there, but those are pretty blunt instruments still, I feel like, the quality measures, and they don't get at all of the things important to patients. So I think paying based on quality is obviously where we want to go. And I think thinking outside the box more, like sort of what you're saying, and both of you are saying, in that we think of health care as just like the hospital and all of these expensive tools and toys we have, whereas really it's much more important to talk about like the built environment, access to food, social media, like phone use, screens, all those things are really so much more, and social determinants, so much more important for health. Healthcare is such a tiny little piece, and it's such an outsized proportion of our budget nationally. And if there's a way to like use that with more precision for people that really need it. I mean, there's incredible advances at MSK, like the drug development and the advances people have made in cancer care and literally, lengthening survival and curing patients that, had a terminal illness 20 years ago that's now completely curable. That's amazing. We don't want to diminish that at all, but it's like it has all these ripple effects where now it gets used outside of that context sometimes, or so I think just focusing more on all of the things when we say health more and less on healthcare, maybe.
That was so beautifully said. I honestly think that we could have a whole nother podcast just on that topic alone.
Yeah.
Because it truly is something like, and I love that you like even mentioned like social determinants of health, because that's not something that's like implemented within our healthcare system right now, to kind of like, I have seen it more so like these days, like different like hospital systems are like asking these questions that really matter, and like really trying to determine what are the underlying factors that aren't directly like the physical like symptoms that are portraying in a patient. So yeah, I really, really did love that answer. And I think that both of those were just like so insightful and incredible. So I guess this is like kind of like pivoting a little bit more towards like practical advice, maybe for some of our listeners. So I guess let's say someone in their 40s who has never really thought about their own end of life preferences or like death and things like that. What do you think is the most important document that they should create literally this weekend? This one goes for both of you as well.
Okay, I'm like, David, you
I'll buy you some time. Quick answer. I would flip the question a little bit and say, if you really want to spend any time this weekend, it's probably not creating a document. It's probably having a conversation. Or if it is a document, it's not an advance directive that's witnessed and notarized. It's a couple of paragraphs that you email to your family, close and extended, about what's important to you, and how you'd want to spend whatever the last period of time is.
That's so interesting. Not a document, but a conversation. I love that.
I think don't get outside, get in nature, read a book, like get off your screen. Don't create anything. Just live in the moment.
I love that.
I would say that. It's funny, when I started doing research in this area back when I was a fellow, we got all these people together because we were looking at a do not resuscitate pre-hospital DNR. And these ER docs who were part of the panel came and they were like, oh yes, I have a pre-hospital DNR. I'm like, you're healthy and you're 45 years old. Why would you have that? What if you had like an arrhythmia that was completely shockable and you could come back and be fully functional? Why would you have a pre-hospital DNR? And they're like, oh, well, I never thought about it that way. I'm like, what documents should you not create?
Yeah. Tear this up right now.
Yeah. I mean, it was just, I think she thought she was being, I don't know,
considerate maybe. Yeah.
I mean, it wasn't done, like the road to hell is paved with good intention, but like, I just honestly told her, like, you really should not, in my opinion, unless you're, I think she was trying to avoid being on, in a vegetative state on a machine. And it's like, well, there's a different way of getting to that. Like David's saying, you can have a conversation, you can appoint, simple thing is just appointing a healthcare proxy. Like, who is that person that knows you the best and all of that.
I love it. I feel like the theme of this podcast is just communication and talking with the people that, are going to be there for you through those last stages of life, and really having open and honest conversations with your healthcare providers as well. And hoping that your healthcare providers are having open communication with one another too. And so I think that really communication is what makes the world go around, whether it's in business, healthcare, like relationships, everything like that. It's definitely great practical advice to give for sure. So this is one question, excuse me, that I've been really excited to ask all day. And I've been looking forward to see what kind of your answer is on this one. But so as we've kind of been talking about, you're sort of shaping the future of how we die in America. And it can be difficult for me at least, to like conceptualize like what success would look like in this mission. So I guess, like, what does that look like for you? Like, what do you think is like, you're like, okay, I've done what I needed to do. This has been a successful mission for me.
Oh, I would love if I did not need to practice emergency care anymore. And there was, when I started as a resident, we used to talk about car accidents. And a car accident is not, it's a misnomer, right? Because most of those so-called accidents were completely preventable. So we started calling them car crashes. So we had seatbelts, we can have better signaling on the highway. We can, there's all kind now, how many people died in a car crash? Not, thankfully, much of that has gone away. And as we get like driverless cars, it's going to be almost down to zero, right? Hopefully. But I think I would love it if, people who had pain crises at home could be managed at home such that they didn't need to come to the ER. I mean, I'm here, we're open 24/7, but like, I think that would be success for me, is no longer needing emergency rooms because we're doing the right things such that they're not needed anymore, because we're taking care of people where they want to be taken care of, and they're not coming and sitting in the waiting room for 10 hours. So that's been my dream for many years, but I would love to put myself out of business.
I think genuinely anyone who sat in an emergency room with someone or for themselves
would agree.
Agree with you. Like, get rid of them. Like, what is that for?
Well, we can't get rid of them, but I would love to fix it so that they weren't needed.
Yeah, no, absolutely. I mean, personally, unfortunately, I've been in an emergency room way more many times than I would have wanted, at least in like the last year and a half, 2 years. And I can tell you that it was not a positive experience any of the times, unfortunately. And it's, again, to no fault of the amazing providers that were there. It's just the way that things are set up, and just, it's not a space that's conducive for productivity or like healing, like, I guess it's just like, but I guess you're not supposed to heal an emergency room anyway. Go there, get your bandages, and go heal elsewhere. But yeah, like, speaking of, like, I just heard you mention driverless cars. And so I do think that you're kind of like someone who's more so in tune with like innovation and, like technological advances in the space. So I guess, what are some like promising opportunities for innovation in this space that you are genuinely excited for? You're like, why isn't someone developing this already? Like, I need this in my day-to-day life.
Yeah, I think in New York, there's an emergency physician that is CMO at a new company. He's a friend of mine, and they're doing ER at home. And so I think there's a lot of really cool using AI to figure out, they've got cars all over New York City, and they can get to someone very quickly. They can do x-rays. A paramedic can go in, he or she can be like the eyes and ears of the emergency doc. And I think there's a lot of neat stuff we can do to bring health care for those who are really sick into the home, because those are the people that really can't come, right? The healthy people that have a more minor problem, it's easy for them to get in.
Right.
But I think the populations that David and I care for, and you, who need care in the home, are really ill, and they, I hear again and again, like the family's like, well, she didn't want to come in. She didn't want to come in. And it's like, well, I get it. They're like forcing the person to come in. The person doesn't even want to be here.
Yeah.
So I think, I think that's where we still need the human touch, but I think a lot of the
barriers,
getting people, getting the services to the right people at the right moment in the right space, is a lot easier using technology.
Yeah. Dr. C, any tools for you that you're like, this would be pretty useful to have in a day-to-day of whether it's, the administrative work or patient-facing work that you're doing?
Yeah, I don't know. My answer is going to be sort of boring. It seems like there are a lot of innovations out there, like the one that Corita mentioned, and like Carayaya, and there are dozens of other examples. But there's not a system out there. It's like we're creating lots of different sized bandages for different problems, but there's no system by which you can go from one Band-Aid to another to another. Horrible analogy. But one of the biggest challenges we see is somebody who really doesn't want to be in the hospital, doesn't have adequate caregiving resources at home, doesn't want to go to a nursing home. That's one kind of niche example, but it's a big one. And we fail those patients all the time. Like, there are acute care resources, we can do telehealth, but those are just Band-Aids on a larger problem. And it's a lot to do with social determinants of health. We're getting better at measuring those, not so good at acting on them maybe. But thinking about, like, if you need a knee replacement, there is a protocol and there is a system, and what happens on day 1, 2, 3, 4, 5. Thinking about end-of-life care the same way. Hospice is a big Band-Aid, but it's still just a Band-Aid because it doesn't cover all the skin that needs to be covered. So thinking really more systematically is, some health systems and health plans have started to do, but some of the Medicare Advantage carve-ins make that even more challenging, because who knows what kinds of benefits you'll get through hospice if you're a Medicare Advantage patient. It actually makes the system more fragmented. And I think we need more homogeneity and more wraparound services rather than less.
Yeah. No, it's just like so much to think about, like there's, And I think that like a one-stop shop, like you were kind of saying, for like these health innovations would also be really, really helpful, not just for physicians, but for people like just your average Joe to like see what their options are and kind of what resources are available out there for them. I'm going to ask you guys one more question, and then I think there's a couple of comments from the audience that I definitely want to get to as well. But I kind of asked this at the beginning, but I'm going to change it around a little bit and see if throughout the span of our conversation, your answer has changed or if there's any additional things you'd like to add. But if our listeners are to just walk away from this conversation with one thing that changes how they think about aging, death, or caregiving, what should it be? Take your time with it too.
Corita, you go first. I feel like I've been hogging your spotlight.
Oh no, not at all. I think it's a really good one. I think living today, not curving our head too much to the past or looking too much to tomorrow, but just being in the moment.
Absolutely.
Yeah, whether we're, I'm not sure who the audience is today, but if you're professionals focusing on that moment with the patient, and if you're a patient focusing on, you're not a patient all the time. You're a person living with a disease. And I think that language is really, really important. We don't say, oh, this patient has cancer. It's a person living with cancer because we're living for many years now. So
absolutely.
Yeah.
I love that. Patient first or person first language is
person
so
first.
and so beautiful.
Exactly.
Dr. Casarett, do you have anything you'd like to add to that?
Yeah, sort of. I mean, I think one take home that I didn't anticipate coming into this is that there are people like Corita who are out there who are trying to shape and innovate healthcare, particularly like the not so sexy aspects of healthcare that happen near the end of life and nursing home care, right? I mean, we always hear about the latest advances in cancer care or cardiothoracic surgery, but advances in nursing home care, those don't make the front page of the Times.
Oh my gosh.
I think there's a tendency to think about end of life care as one of these wicked problems like poverty or truancy that you just can't solve. But I think one big take home is that there are people like Corita who are out there who are saying, yeah, there are definitely problems with the way the health care system is designed and the way it delivers. But those aren't problems we necessarily need to live with. And we've managed to fix a lot of other problems in society over the last 100 years. Like we can make some progress in healthcare. So I think that having people like Corita out there who are beacons of innovation should inspire, especially younger learners, to think, we don't really have to accept the status quo. Things could be better. Things could be different. We can try, fail better, and make some progress. And I give Corita and folks in your area a lot of credit for being those innovators.
Oh,
I love it.
Generous. Optimism is a choice. That'll be my last. Optimism is a choice.
I love it. Optimism is absolutely a choice. I'm going to try and go through both of these questions quickly, but we have, you've been part of so many innovations in emergency and palliative care, and it's been really cool to hear about your hopes for the future. So our listener wanted to ask, if your younger ER self were to shadow you today, what do you think would surprise/excite her the most about the work that you're doing now and how you're doing it?
Oh, that is so interesting. What a great question.
Right? I love that one.
Yeah, I don't think when I was a medical student and I fell in love with emergency medicine, I loved the pace of it and the teamwork, but I had no idea that communication would be so important. And I think there was a college student shadowing me at my last shift, and she was like, "Oh, you're so kind, and like your demeanor," or she said something about like the way I speak with people, my people skills. And I was like, oh, wow, that is so nice. Cause that is pure. Like if a student comes to you, I mean, we're so jaded, right, David? I mean, hopefully we're not. I try not to be,
right.
But I think when I remember being a student and watching older physicians or experienced and being really disappointed with their I mean, I don't remember I had the opposite feeling. Like I walked out of the room and was like, wow, that person was really mean to the patient. Like that was always how I left. Honestly, I was at UCSF. I never saw a good role model in that way. And so I think I felt so much pride when I walked out. And this wasn't even a med student. It was a college student who, you know, yeah. And I was like, oh, that's really nice. I don't know what I did differently than anyone else, but like, thank you so much that you made my day.
Well, honestly, I can ditto the sentiments of that student because I have just spent like the last 45 minutes with you, and I can say that you are someone who truly is putting your heart into the work that you're doing, and it shows just from the way that you speak about it and the ways your like eyes light up when like a question that you're excited to answer is asked. So thank you for doing the work that you're doing, because it's tough being a physician right now, and you are genuinely doing the Lord's work, honestly.
Oh, no, it's a privilege.
This one seems like a pretty quick question, and I'm excited to know your answer too. But we have another listener that said that was a beautiful Emily Dickinson quote from earlier that you mentioned. Are there any non-medical books / movies / experience that has shaped the way you think about care or leadership?
Oh, wow.
Movie racks for the audience.
Yeah, I read a lot. It's one of my like favorite things to do.
I love that.
Yeah, I think one of the most important books that I read that relates to medicine was The Spirit Catches You and You Fall Down. It just made me rethink. Anyway, highly recommend it. I'll leave it at that.
Spirit catches you when you fall down. I wrote that down so I can add it in the comments.
And you fall down.
And you fall down.
Yeah. So it's a story about a Hmong family. It's written and about their experience of their child having seizures, and then the medical interpretation of that. And to them, yeah, it's such a nuance. I've read it twice. I don't read many books twice, but it's really beautiful. And just goes to like how sometimes we can just be right with each other and completely misinterpret.
Immediately getting added to my read list. So
yeah. That's really good.
I really appreciate that. I appreciate your time, your energy, the work that you're doing. It has been so lovely chatting with you. Thank you to my wonderful co-host, Dr. Casarett, for being here with us today as well.
Thanks, Corita. This was awesome.
Thank you so much for inviting me. This was the highlight of my week. So
I had such a good day. I mean, honestly,
Monday. You can't say that. Like, we'll check back with you on Friday.
Okay, yeah. Tell me all about my woes of the week. Yeah. Thanks a million. Thank you.
I'll definitely be in touch because we would love to potentially do this again sometime. So thank you so much for your time. And yeah, bye everybody at home. Thanks for listening in.
Bye.
Thanks.